Good morning or afternoon, everyone, depending on where you are. This is Zena Dott with JBS International, and thank you for joining us for today's Opioid Use Disorder, Pregnant Women, and Neonatal Abstinence Syndrome, Addressing the Challenges, Part 2. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at rcore-ta@jbsinternational.com. We request your participation in a short evaluation survey that will be sent via the chat box towards the end of the webinar. We thank you in advance for your participation in this webinar as well as the survey. Lastly, this is a recorded event and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available and sent to participants at a later date. Today's presenters are Carrie Earle and Sharon Morello, both technical expert leads with JBS International. Carrie, I'll turn it over to you.
Thank you, Zena, and welcome everyone. It's nice to be back with you for part 2 of this webinar, and as we acknowledged in part 1, we're covering a lot of ground at a relatively basic level. So for those of you that are looking for more, there will be follow-up to this as we dive further into this, but for today, we're really kind of taking a 101 approach to covering some issues that perhaps not everyone is aware of. So today we're going to cover strategies. Last week we talked about some of the issues and challenges that women bring with them to care, and so today we're going to talk about strategies for addressing those for the woman, their infants, and their family members. We're also going to look at key partners and resources and think with you about how you might assess the landscape in your state or community for potential leveraging opportunities. So with that, we can switch slides. So starting out looking at strategies, we're going to be talking about outreach and engagement practices, screening and testing, and some of the considerations around screening and testing practices, what best practice care looks like in multiple settings, and how to build recovery support starting with mom. Next slide. So when we think about those issues and complexities that we discussed last week that women bring with them into care, one of the things that we have to acknowledge at the front end is how difficult that outreach and engagement can be for women who have every reason to distrust coming into the system, and so for that reason don't come into prenatal care or other services as early as we would like to optimize health and safety outcomes for mom and baby. So as we think about effective strategies for that, we want to make sure that they're welcome into care regardless of where we encounter them or they encounter services. And that can include domestic violence programs, harm reduction programs, crisis intervention. It could also be in the context of community service settings like food banks and libraries. And so really think through in your community where women at risk for OUD, SUD are likely to be. And effective strategies to include are listed here, and really that home-based mobile outreach is one that we want to highlight. As I mentioned, we're going to be talking more about screening and assessment practices, peer support, but also looking at some just fundamentals, being respectful around getting them into care timely once they've indicated that they're willing to come in. And that can sometimes be supported with some pre-engagement or pre-treatment intervention groups. Next slide. The 3 major components of outreach for pregnant women with OUD, SUD are frankly similar to outreach for all individuals with OUD, SUD, where we want to look at what are their most urgent concerns and make sure we're addressing those first before pushing an agenda that doesn't fit. which is all the basis of motivational interviewing. And so you'll see here the highlighted best practices and evidence base that supports these major components. But that notion of empathy, we're going to be talking more about that in the context of trauma-informed care, making sure that she understands that we're part of her team and that she's a part of decision-making. And then assisting with that complex human service system navigation, making sure that there are warm handoffs and connected referrals rather than just handing her a phone number. Next slide. And all of that is grounded on making sure that there is the ability to build a trusting relationship at the beginning of that interaction. And in order to do that, and this is very unique to women, it's important to understand that there are others in her life that are going to influence her decision as to whether or not she wants to engage. And so her children and her other family members, whether that is partners, however she defines her family, it's important to understand that building trust with her means incorporating an understanding of who she has in her life, what kind of environment she has in her life as well, and so that the environment that you're creating is one that is perceived as safe and welcoming. Making sure that we're not just looking at trauma-informed training for the care team, but across all job functions. From the minute that she walks in, whatever door she walks in, that trauma-informed care begins there. And utilizing universal screening, Sharon's going to talk more about that, along with expert practice, and some of these other dynamics that we've kind of addressed. I'm going to go fast because we have a lot to cover. You're going to be getting these slides, so forgive me for when I'm going to race through a couple of items to make sure we get through and have time for questions. Next slide. So importantly, part of engagement is to think ahead of what kind of barriers you might need to be addressing at all of these different levels, from interpersonal to systemic. And we've talked primarily about the interpersonal issues and potential barriers and the intrapersonal ones. But we also need to think about what's happening at the cultural level, what's happening at the structural level, what's happening at the systemic level, all of the things that may be getting in the way so that we can figure out how to, if not overcome those barriers, at least navigate around them. Next slide. And a way to do that is really making sure that we are addressing stigma at the front end. I had a very dear friend and colleague who reminded me that stigma really is a substitute word for, and that we should really start calling stigma for what it is, which is discrimination. We really need to look at how are we and where are we in our communities showing, where is that discrimination showing up, and start to educate around that. So at the community level, looking at, you know, the family and individual level and where social settings occur, but also, you know, what are the lawmakers and policymakers, where are their attitudes at, where are some of the service organizations, just all the different aspects of community. And we know that stigma and discrimination doesn't only occur kind of out in the community, but really right within our healthcare systems is where some of the most discrimination occurs. So it's going to be important to build in the training that is part of what this webinar is about, helping people understand that people with OUD and SUD, and women with OUD and SUD, and especially pregnant women with OUD and SUD, have a lot of things that have brought them to this place and bring them to this path, and understanding that in order to provide compassionate care is fundamental to recovery. Next slide. So Sharon, I'm going to hand it off to you to talk about screening and testing practices.
Yeah, thank you, Carrie. So hi, everyone. I'm going to talk about screening and testing for a little bit, go through a couple of slides, and I'm going to hand it right back to Carrie to finish up. So we're going to talk about screening and testing, what kind of screening, maternal, infant, biological, and then some of the ethical considerations that we need to consider when doing all of the above. Next slide, please. So screening for OUD, SUD determines whether a pregnant woman needs an assessment. We want to do that screening early enough with interviews, questionnaires, and sometimes using toxicology tests. And we'll talk a little bit more about toxicology in a few minutes. The screening should be universal and it should be comprehensive. We should be looking, and by universal, we do everyone. Everybody who walks in the door is going to get that same screening. Past, present, prescribed, illicit substances, all should be discussed and talked about. Certainly methadone, buprenorphine, any of the medications for the use of opiate treatment medications should be discussed and asked about, but all medications. So if she's on medical medications for any other medical comorbidity or for psychiatric purposes, we need to know about those. And not forgetting about the most common substances of use, alcohol and tobacco. Other high-risk behaviors, injecting, drug use, exposure to violence or abuse in the home, infectious diseases, knowing that STDs right now in the country are on the rise, and looking at hepatitis B and C as well. The behavioral health comorbidities that might be happening, and especially around the two most common ones, which would be depression and anxiety. Are those being treated? Is the medication? Is there an underlying disease that's not been looked at all? So next slide. When we're talking about universal screening, we're talking about a recommendation from the American College of Obstetrics and Gynecology, who way back in August of 2007 recommended that we do universal screening. And that means that we get the opportunity to do early intervention, early identification, and minimize the potential of harm to the mom and the baby, and to maximize the opportunity to motivate her to make some changes. An early assessment using universal screening. When we do selective screening based on what we think are risk factors, or there was poor adherence to prenatal care before, or prior adverse pregnancy outcomes that happened before, we end up missing cases by not doing the universal screening. And then we are also identifying the fact that we might be stereotyping and using stigma to do screening on particular people who come in the door versus everyone. Next slide. Some of the barriers to screening are pretty interesting. A lot of them are used, basic ones. Oh, we don't get reimbursed to do that. This is a time constraint. We only have a half an hour to do such and such, and we need to do these other things. And other people may find a barrier or use barriers to say, if I do the screening and I have no place to refer, why am I doing this kind of assessment? The really interesting piece about it is that we have a real identified need that our medical professionals as well have personal professional discomfort around even asking the right questions. Carrie talked about stigma and bias, but we don't ask those questions to everyone. We find we skip over them if we're uncomfortable with them. And there is definitely lack of training on SBIRT, but not only SBIRT, but lack of training on substance use disorders in general. I'm going to give you a quick example. Took a family member into the emergency room before the pandemic came. It was early in the morning. It was about 3 o'clock in the morning with the temp of 103.5. The nurse in the triage ER was doing questions, and before she asked this question, she said, I really hate to ask you this question. I know it's uncomfortable. It's uncomfortable for me. I don't know why they make us ask this question. It's kind of stupid. And then she proceeded to ask the family member if they were suicidal. So based on her preemptive discussion about what she thought about the question, really would have allowed the person to actually answer it the way they would have, or did we stop the conversation by preempting the conversation? So it's interesting to note the way we ask questions and engaging changes the answers to the questions. Next slide. So this is a busy slide. I'm not going to go over all the pieces, but you got to recognize that there are all kinds of screening instruments out there. Here are examples of that. And I won't go over all the detail because there's way too much, but to recognize that it's not just the screening tool that's one that's better than the other. These all four are very good and evidence-based screening tools. However, the fact that we're using the same one, that we're teaching to fidelity when we're using it, and that we use it in a universal way is the most important part of the screening tool. So there's 4 Ps, not a quick screen. We have the other one, the Institute of Health and Recovery integrated 5P screening tool. And then we have the crafts that's available as well. Next slide. We talk about informed consent for pregnant women. We should be asking if we're going to be doing any kind of toxicology screen, whether it's a urine sample, a blood sample, a saliva screening, any of those, we should be asking for a signed paper or electronic form in order to get the permission to do that screening. An oral consent is used most of the time and is not the recommendation for treating the woman. She should be, when we use an informed consent and paper sign, we have more of an opportunity to identify risk and limitations for each type of test. We can let her know that if the test comes back positive from a screen, that there are confirmatory tests that can be done, that the process for the test and what happens to the specimen and what goes on, and then what are the legal implications of testing for the mom. Next slide. So you do not rely solely on toxicology screens. When someone comes in and you're trying to do screening and they test positive for something in a urine or a serum screen, that doesn't automatically identify that this person has a substance use disorder, an opiate use disorder at all. And the patient needs to be interviewed and talked about those substances as well as using the toxicology screen. Mom needs to have an informed consent. The baby does not need to have informed consent, and that's true for across the country. All healthcare professionals must understand that their legal responsibility for reporting an exposure, and that needs to be made clear to the mom as well. One of the things I'd like to say about toxicology screening is that we need to make sure that we recognize that it's a screen and not a test, and that when tests come back positive, they need to be verified for confirmation because many times they're not accurate. They could be false positive or they could be false negative. Next slide. And now I'm going to hand it over to my peer, Carrie.
Thanks, Erin. Okay, so we move into the idea of what approaches work. I think it's important to look at these concepts as applicable across multiple settings, as I said at the beginning. Next slide. We're going to start with family-centered care, which is really a concept that emerged in residential treatment for pregnant and parenting women back when SAMHSA started providing funding for this population back in the 90s. And as we've learned over the last couple of decades, family-centered approach really is one that recognizes that substance use disorder is a family disease. It impacts the family as well, and that the family impacts recovery. Well-being occurs in the context of family for women, for everyone, but for women as relational beings and caregivers, it's particularly important. And some of the dynamics and hallmarks of a family-centered approach that can be applied in multiple settings are that you're looking at all of the needs and strengths of all of the family members in order to understand how to encourage retention and care, improved child well-being and family well-being, and improved parenting skills and capacity. Next slide. One of the important ways, starting in the hospital, that family-centered care can look is by supporting the mother and infant dyad. Too often in both healthcare and other settings, we split the interests artificially of mother and infant by planning separately for them, addressing their needs separately, and often disconnecting their interests. So this is really an optimal time to start supporting that mom-baby dyad in that neonatal period, and even prenatally, finding ways to support clinicians in understanding that by supporting this dyad, it's going to positively impact the health and recovery outcomes for mom and baby. There are studies that show that nurses that do demonstrate this kind of caring and compassionate, empathic behavior towards moms were better able to help them understand their infant's cues and further improve that mom-baby interaction. Next slide. Rooming in is another important intervention that is family-centered and facilitates breastfeeding. It has resulted in shortened hospital stays, a reduced need for medication, and it is the recommended approach to care. Next slide. So when we think about a trauma-informed approach, you'll see on these next couple of slides, there's a lot of alignment with what we've talked about previously in terms of outreach and engagement and family-centered care. So a trauma-informed approach, and this is with SAMHSA's guidance that was published back in 2015, it realizes the impact of trauma as well as the multiple paths for recovery based on what works for a particular individual, recognizes the signs and symptoms in clients, families, staff, and other stakeholders, and responds to those by integrating knowledge of trauma into policies and practice across the organization or system, and most importantly, seeks to prevent re-traumatization. So in the context of thinking about moms and babies and keeping families together, this is a major driver. Next slide. Basic principles to guide trauma-informed care are to support the sense of safety and trust that we talked about previously, engaging peer support, and ensuring there is empowerment in both voice and choice. So we're not saying to mom, these are your options, without truly giving her options and allowing her to opt out, and making sure that we're taking into account her culture, her history, and her gender. Next slide. So speaking of gender, we've learned over the last couple of decades that gender responsive care is important for women with substance use disorders to be able to identify with someone that they perceive is relatable and looks like them is an important trust building aspect. There are a lot of anecdotal as well as research stories around the importance of making sure that even, and this is not, by the way, to say that male clinicians and care providers are not effective. That's not the point here. It's really to look at matching and sensitivity to how women show up with other women versus other men, especially in early stages of their care. Next slide. So finally, the component of effective practice around care is that it is culturally grounded. And what does this mean? This is a hot topic right now, and rightfully so. And I think one of the important points one of my colleagues made recently in a meeting was the notion of cultural humility as opposed to cultural competence. That the cultural humility is coming to the care and the intervention and the interaction and the relationship with an appreciation for what you don't know as much as what you do know, and being able to have this self-reflection that is about seeking better understanding of the person that you are there to help and the family that you are there to help. So that person may come in with a very different experience of the world and a different way of knowing. That is a indigenous ways of knowing as a reference to tribal cultures, and it also expands to multiple cultures that people come into an experience with their own way of understanding. And part of our relationship and trust building is to help learn what that is and work with that. Next slide. So what does that look like in terms of delivering care at our individual practice level? It means approaching something with respect, even if there is a lack of understanding or a lack of agreement with your client's worldview, an acceptance of that person, non-judgmental acceptance, and sensitivity to what they've experienced around the racism, stereotyping, discrimination, including from your organization and from you. And then going beyond that respect and acceptance and sensitivity to committing to equity, making sure that moving forward and looking ahead, that you circumvent the racism and bias by removing it from practices and policies that you may not even necessarily understand or appreciate have a component that is expressing bias or racism. Openness, humility, and flexibility to the approaches, I mean, where there's a lot of pressure to have an evidence-based approach and practice, but we also need to balance that with understanding that what's evidence-based also has to be balanced with what's culturally sound. Next slide. So now we're going to move into talking about how to build up a mom and a family's recovery capital, starting with the discharge planning process, moving into how to utilize peers to support and build that recovery capital, and in the context of continuing to address stigma post-discharge. Next slide. So now you're going to see, I've been talking about the mom-baby dyad, and now we're going to talk about how it splits in discharge planning. But what the important point here is, you've got a maternal discharge plan, you've got an infant discharge plan. They need to be integrated. Even if they're distinct plans, they need to be complementary plans. So for mom, making sure that she's screened. We talked last week about the heightened risk for postpartum depression and how that impacts recovery and relapse. So making sure that screening happens both at discharge and then again at the outpatient appointment, that you're constantly checking in with mom on what's going on for her with her mental status, and developing a safe care plan. We're going to talk here in a minute more about plans of safe care, making sure though that she has a safe care plan that is safe for her parenting, for her ability to navigate what's going to be a tough transition under the best circumstances of having care for a newborn and a change in a family system. So making sure that she has strategies that she can use if she gets stressed or feels like she's getting unstable. Next slide. And that includes, of course, ongoing medication-assisted treatment. That wasn't in the slide. That was a point we made last week, and I just want to reinforce that here. So for the infant discharge planning, it's ideal and desired that mom and infant leave the hospital at the same time. We know that that's not always an option, and making sure though that in preparation for leaving the hospital, that discharge planning, particularly with the infant, starts, but with both mom and infant, starts before birth. 80% of infants can be weaned from methadone or, and Sharon, correct me if I'm wrong here, morphine within 5 to 10 days.
Yes, that's absolutely correct.
Okay. Sometimes we know, though, that infants do remain in the hospital after mom is discharged. So it's critical that we support her ability to be with her infant, to room in and breastfeed even when she's already been discharged, and also to support other non-pharmacological interventions for that mom and baby. Discharge planning should definitely include home visiting and early intervention services. So making sure that there is a home nursing consult, a social work consult, and attachment-based parenting support, which often comes through home visiting. making sure that all the referral to the healthcare professionals that are also going to be in that family's life are knowledgeable about care and treatment of NAS and what its impacts are and what its impacts aren't, making sure that we are not overreactive to a treatable condition, but that we're just preparing the family to be able to manage that condition, and we're prepared to support the family in managing that condition. Next slide. So plans of safe care, which many of you may have heard of and many of you may have not. In 2016, the Comprehensive Addiction and Recovery Act, which is shorthand CARA, amended the CAPTA Act, which is Child Abuse Prevention and Treatment Act. And CAPTA has been in place since the 70s as a child welfare legislation, and it's been amended several times during that, between when it originated and now. But in 2016, CAPTA was importantly amended to clarify which population of families need a plan of safe care. And very importantly, they removed the term illegal with the intent to ensure that supports for families were put in place prior to hospital discharge for infants and their families who were impacted by prenatal substance exposure. The legislation requires that the plan of safe care is offered to both infant and family or caregiver. So that also is important to see a plan of safe care as a tool to be leveraged to support this mom-baby family post-discharge connection. Next slide. So it is distinct. It's important to note that a plan of safe care is not a child welfare or child protective services safety plan. That there are three populations of women for which plans of safe care are relevant. And this is an important thing for healthcare providers to understand, because the tendency, at least in the groups that I've worked with over the last few years, is at the outset of trying to understand who a plan of safe care gets developed for, the tendency is to really lean into group 3 here. But it's important to understand that there are two other types of situations and scenarios that also warrant a plan of safe care, including women who are using legal or even illegal substances, but they do not have what would rise to the level of a substance use disorder. So there isn't a risk or safety concern for the family in that situation. But nonetheless, that family is vulnerable and at risk and needs to have, so maybe I should have actually used a little bit of different language there, but nonetheless, that family needs to have some support as a preventive and proactive measure. Group 2 includes women who are stable and in treatment, actively engaged in treatment for an OUD, and again, would benefit from having additional support around infant and mom. And then the third group is the unmanaged substance use disorder, where they're not actively engaged and are at higher risk. So there's an overlap between the child welfare interventions and the plan of safe care interventions, but it's important to note that there are differences and that they're not, one does not equal the other. Next slide. So there are some good best practices around development of plans of safe care for you to consider. And again, I think this is where this really offers an opportunity is in those communities where this may not be something that is regularly practiced at the hospitals in your particular town or your community. That there has been kind of an uneven application of plans of safe care since 2016 across the country. Some states are very engaged and have really developed statewide protocols, and they're available. The National Center for Substance Use and Child Welfare, I'm going to show you their slide in a minute, and we mentioned them last week as well, have incredible resources available and good models and tools to help communities who have not gotten that developed in developing their own practice. So I encourage you to reach out to them. But these are some of the best practices around plans of safe care. And I've already made the point that they have often been mostly focused on the infant, but the plan for mom and services for mom and other family members is equally important. So making sure that part of what they have the opportunity to do is instill confidence in mom that she's able to care for herself and her newborn. Making sure that they're used to build trust and relationships with providers and link mom and baby to services, facilitate connection to resources, and improve access to care that's inclusive of the spectrum of needs, mental, emotional, physical. Next slide. So the National Center for Substance Abuse and Child Welfare has developed this planning guide, and I would encourage you, you all are going to be seeing these slides after the webinar today, so you'll be able to take this and download it, but this is an excellent tool. Next slide. And another resource that was from the National Center, and I love this slide. So since this is a quick kind of cover a lot of ground webinar, this is going to be one slide that really speaks to the impact of peer support and recovery coaching. This was a study that was done in Cook County, Illinois, and with about 3,400, a little over 3,400 families. And what you see here is the compelling difference that a recovery coach makes, that in being offered comprehensive screening and assessment as well as priority access to care, those two things alone were not enough to impact reunification. But when you add the recovery coach component, it resulted in a 31% increase in reunification. So it's a really powerful way to underscore how much it matters to have that peer support, that navigation support, in an ongoing way post-discharge. Next slide. So that's kind of a good segue into looking at your options for collaboration, and that really begins with the mom and her family, and also extends to other healthcare providers, community agencies, and then the broader landscape. Next slide. Starting with mom, here are some of the ways that we can partner with mom during care and post-care, post-discharge, providing information and education to her that is supportive about NAS rather than non-judgmental. A lot of moms come in with an incredible amount of shame and guilt and fear about what's going to happen to their baby. What did they do to their baby? So really important to collaborate, engage with her, be on her side, provide her with the kind of peer support and education and emotional support that keeps her confidence alive in order to be able to move through that guilt and shame. And take advantage of all of the motivation that that relationship with her newborn is going to provide. Next slide. So continuing that therapy, there we go. Including that, or continuing that therapeutic relationship is very empowering because you're able to help her, handhold her through those connections, handing her to, or connecting her to home visiting, and which is a proven strategy for supporting recovery and supporting families in their own environment, making sure to help establish what a healthy home environment looks like. Again, important to note that this has to be decoupled from poverty and cultural racial bias. That is a problem in the child welfare system, and home visiting is a nice way to bridge that gap. Providing family planning and contraception options, and then we've already talked about developing that dyad-centered plan of safe care. Next slide. So beyond the immediate family collaboration is the importance of collaborating with other healthcare providers. And we see this a lot, that within the healthcare system, there are a lot of silos and sometimes not great handoffs or care coordination. So this really is an opportunity to look at, again, that education component and stigma reduction component, providing supportive, non-judgmental interactions with parents, and making sure that the care team approaches the family and the care provision with support rather than judgment. Making sure that there is an understanding across both providers and management and admin staff on OUD and pregnancy, and dispelling some of the myths and misunderstandings about that, and what are the best practice strategies that include things like breastfeeding and rooming in to support families. Next slide. Let's see. I think we've talked about all of this, so I'm going to keep moving. I think the main thing here to highlight is just that direct communication with the outpatient provider. So making sure that pediatrician and mom's care provider and any other specialty care providers that might be in the mix have communication and are part of the discharge planning process prior to discharge. Next slide. So in thinking about, a lot of times the disconnect happens at hospital discharge largely because there is a lack of information about what resources are available and a lack of connection to those resources. So being able to support the collaboration and the connection from the hospital to the community means being able to keep that list of resources updated and accessible for both families and for care providers. And this really should start prenatally. A lot of times, back to Sharon's earlier point about some of the barriers to screening include not knowing what's available. So there's a lot, we hear a lot of, well, I'm going to identify a problem for which I have no solution through that screening process. So really understanding the resources and how to access them, making sure that care providers and moms both know how to do that, and building the relationships with those programs to be able to ease those referrals is important. Next slide. Some of the main programs that are at the forefront are going to be early intervention programs, child protective services, and I want to say about the child protective services relationship that it's important to build that in a positive way to help moms to start working with families through those system connections to dispel some of the understanding. You know, maybe CPS in a given community isn't always coming in to take the baby, but that's the reputation. So health care providers have a really nice opportunity to partner with agencies and systems, criminal justice included, and build that relationship with families across multiple systems. We've talked about home visiting, and Sharon also highlighted the importance of, oh, sorry, this is not informed consent. The ability to support information sharing, and it means being able to come up with a release of information that a mom is willing to share because you've done a good job of building trust, and that helps to support care coordination moving forward. Next slide. Some of the ways to think about this are looking at all the different ways that communities do support moms. Some of them are built in through federal mandates and legislation, things like TANF and SNAP and WIC, and there are other things that are available, but you may not necessarily know where to look. So these are some of the different potential ways that communities do support families in recovery through housing, childcare, transportation, employment support, legal aid. Look to see who's providing those services and how you can better partner with them. Next slide. And this is really getting into looking at starting with your local level, but moving on to all the different layers that are at the state and the national level, ways that you can leverage opportunities to build capacity to serve these families better. So these are some of the different places and systems or agencies or initiatives that we would encourage you to look to as you think about both need in your family and how to engage and what's available to be leveraged. And importantly, sometimes a seat at the table, it can be the primary outcome of a partnership, and an important one, because being able to be at a place that you perhaps weren't previously, whether that is at an advisory board table or a regulatory body where you can start influencing practice and policy decisions with decision makers that are going to benefit better recovery and health and safety outcomes. Next slide. So again, just think about who else is working with or for this population in terms of who you might partner with. Some of these are obvious, some of them not so much. Colleges and universities often have a lot of, whether they're grant-funded programs or education or research-based programs that might be of huge importance to you in partnering. There might be early intervention programs that are, or child care programs that are college and university based. So that's one of many examples of just thinking through how you might assess your community or your state or your county for who you need to be partnering with in order to start sharing and maximizing resources that are available. Next slide. We wanted to put a spotlight on perinatal quality collaboratives because a lot of folks, especially outside of the healthcare system, aren't familiar with these, even though most states have one that are either active or in development. So PQCs for short are state or multi-state networks of teams that are supported by CDC to improve the quality of care for moms and babies. And their membership, and this is important, typically includes these kinds of entities. So even if a PQC isn't focused on NAS or prenatal substance exposure, it's still important for you to know the one in your state and who these players are in order to connect with where the energy is around maternal and child health. Because they are really focused on and supported to build up evidence-based methods, and you're going to see in a minute an exciting product from California's PQC. These are really good places to go and find toolkits and other great resources so that you're not reinventing the wheel. Next slide. And you can see, again, their area of focus isn't always on NAS, but that is certainly one of the primary focuses. And I think the last thing I saw was, so I think it's bigger now, but in 2014, there was a list of, I think, I want to say close to 14 or 15 states that the PQC was specifically focused on NAS. So bottom line there's just an immense amount of a wealth of information there. And they are moving the needle, and that's important to figure out how to find what's working and where it's working and how it's working. The National Network of Perinatal Quality Collaboratives is the TA provider for these PQCs, and you can learn more at this website. Next slide. So this is was just published early last month, and It is an incredible resource. We would encourage you to look it up along with the other tools that are available at this site. Mother and Baby Substance Exposure Toolkit Best Practices. We'll be getting this up on our own resource portal as well. And these are some of the resources available. So this is one both good and recent example of some of the things that PQCs put out. And with that, I think that wraps us up and puts us in with about 10 minutes for Q&A.
At this time, we will begin the question and answer segment of the presentation. So if you have not already done so, please submit your questions by using the Q&A feature located at the bottom center of your screen.
Hi, Carrie and Sharon. A couple of questions. One is from a NICU nurse who says, my patients that struggled most with substances usually had CPS involvement. Frequently, the infant would remain hospitalized in the care of the state with parents prohibited from visiting without caseworker supervision. Thoughts on how to maintain therapeutic relationships with this ubiquitous circumstance?
I would be glad to try to answer that. It depends on what state you're in, what the regulations are, what the perceptions are, and what mom is coming in with. Has she been maintained with a medication-assisted treatment throughout her pregnancy? Has she received prenatal care throughout that time? If she comes in and she delivers, she's been planning for that. Her provider in the community has been working with her prenatal team. She delivers the baby. The baby is going to go into NAS, and we're going to encourage her to stay with the baby. And depending on what state you're in, that's acceptable. And not only is that the case, but mom can stay into the hospital a little bit longer. She can breastfeed, she can be with the baby, and she can go home with her baby as long as on her medication, as long as there's no other reason that she wouldn't go home except for that she's on her medication. So that's different. And remember, Carrie had put those 3 buckets of different kind of presentations, is that then there's another woman that comes in, has had no prior treatment, and comes into labor and delivery right off the street, still using. And that's a different place. It doesn't mean that we can't do good care with her, but for those babies who are going to breastfeed and stay with mom and do those things, we probably have had some prenatal planning and caring, and that's why that screening and assessment is so early and so important from a universal perspective, so we can catch that early in the pregnancy and begin doing that work, and then delivery becomes a lot different than it would be if we had done nothing. So there are a lot of different scenarios, and many times it depends on what the state agencies have as their rules and regulations around that. I hope I answered that okay. Carrie?
Yeah, I guess sorry, I didn't hear the first part of the question.
That's okay. Well, I think the question was is that, you know, when this nurse has worked in NICU and she has seen where, you know, the baby mom is discharged, she can't be with the baby, they're not allowed to visit. So how do you develop therapeutic pieces when you've got that kind of pull and tug that's happening?
Oh, right. And yeah, I think that, and it's a great question, because I have seen in a lot of communities where, in fact, child welfare might even come in, depending on those circumstances, and remove the baby in the hospital. So there are challenges with that, which is why we're encouraging that collaborative relationship, because by building that teaming approach, you know, there are education and stigma reduction needs for CPS workers and social workers and hospital social workers. And there are a lot of what I would consider low-hanging fruit opportunities to build those relationships between the hospital social workers and CPS social workers, to start communicating as early as possible around what that family needs in a way that promotes and encourages the family to stay together if possible, or to reunify as quickly as possible, but not to disrupt the bonding that needs to happen in that family.
Thank you, Zena. A couple more questions. Carrie or Sharon, do you have any examples of groups that have blended work in the reentry space, helping moms with criminal records that work on providing non-stigmatizing care? So when moms in reentry, helping them if they have criminal records.
Sharon, do you want to talk about Rhode Island?
Yeah, we actually, when we have mom that's incarcerated, and she is coming in and she's pregnant, we actually will maintain her on all her medications during that pregnancy, whether it be methadone or buprenorphine. And then during the course of her stay, she will deliver and she will remain on her medication. And when she is then discharged or released from the prison, a reunification program will be in place. She will stay on her medication-assisted treatment throughout her release from the prison, and then hand it off, a nice warm handoff to a provider that will continue her care for her own treatment, and then work with our local what we call DCYF, Department of Child and Youth and Family Services, to reunify the mom. We're very fortunate that our DCYF state agency has really got on board with evidence-based practices in the care of pregnancy and MAT. And actually they are working with parent support recovery coaches who are actually in recovery themselves, have been on medication-assisted treatment before and during their pregnancy, and are being recommended by our DCYF agency to follow up with our ladies as soon as they're out, as well as from prison, as from the hospital. If there are no other concerns in the home, DCYF does not oversee the baby and the mom when they leave, if they've been doing all the things that should be happening. But also from the prison as well, and handoff to home with reunification remaining on the MAT throughout the course. Our recovery coaches here also are trained specifically for pregnant women, and they actually have gone through doula training. And so they actually support mom throughout that whole first year, as well as during her delivery.
Okay. Carrie, do you have anything to add on that piece, or you want to let that one stand and we can go to the next question?
Yeah, I noticed the notion of the criminal records, and I think that that's a really good ask, but I don't unfortunately have a good example of that specific absence of reentry.
No, I don't either.
Okay. Next question is, where can we find the findings of the collaboratives? And this participant is also sharing a resource from AHRQ on perinatal care, and we'll add that to the resources when we send out the presentation. But where can we find the findings for the collaboratives?
So that CDC's website has that, and that's on the slide that you'll be receiving. And then if you just Google the NMPQC, you'll find more resources there as well.
Okay. And are there any specific resources that you all are aware of for women in rural areas of the country?
You know, I saw that question, and yeah, I think that there are specific resources. That's broad, so I'm not sure which specific resources, if that's kind of just a general question about resources for, but the Rural Information Hub has a lot of good information about this population specifically on their site. So we can probably add that link as well when we send out the slides.
Okay. Next question is, are most places providing universal screening at admission on the electronic medical record or on paper? Or how is that, just the logistics of how that's done in y'all's experience?
I can say that it's in both. And when they're doing that universal screening, at admission. It depends on what kind of system they're in. Either one is fine. The important part of the universal screening is that it's done on every single person that comes in, but not just the screening done, but the staff are educated, and the staff have displayed some information so that they're well versed in OUD or SUD and have the ability to engage in a motivational interviewing type of way, so that they're going to get the right answers on the universal screening. But it can be either or, paper, electronic, depends what system they're in.
Okay. I realize it's about 3 o'clock, but we do have one more question. And if you can hang in there with us, that's perfectly fine. If people need to jump off, we will be providing the audio and the slides for this presentation and the resources we've been talking about on the our Core TA portal in about a week. So next question is, how are all these strategies that we discussed today affected by the various policies at the state level regarding CPS's mandate to take the child into custody if the baby is born with NAS? And what strategies are recommended for educating the hospital staff about interacting with CPS and families in those states that have policies that do not allow the mother to keep the baby?
Yeah, good question. I think that there are a couple of angles here. One is at that kind of direct agency to agency or level where you're working with individual people. So I've seen some very effective examples where by building that relationship, this could potentially be supported through any kind of family court process if that happens to be available in your community. Wherever there might be a collaborative team, and if that doesn't exist, put one in place to look at building enough trust with CPS that, let's say, if mom is in safe and stable treatment and has supports, whether that's a residential setting or supported by home visiting with medication-assisted treatment and cognitive behavioral therapy in place, that CPS has an agreement to allow that family to stay together because they're in treatment and supported. And typically, that kind of arrangement is monitored through a court process. So even if you don't have a family treatment court, but can get your dependency court on board to kind of support that monitoring process, that's one opportunity to keep families together at home and supported. But the other angle is really at that state policymaker level and trying to influence change at that level, which is clearly a heavier lift, but not an impossible one. Have seen a lot of states move in both more restrictive directions and less restrictive directions around punitive policies. But I've also seen states where punitive policies exist have good practices emerge that can support families. It's just a lot harder. So I don't know if that answers your question. It's a pretty complex one and a good one.
Yeah, and one of the things that I've seen in various states is that when there's a champion, and usually the champion is at either the Department of Health level or at some kind of high state agency level where they're bringing together all the important people, whether it's behavioral health, whether it's the birthing hospitals in the area, whether it's child and family services, whoever is there. And those champions actually begin to drive the change, and they keep a strategic plan over the course of time. And I've seen, doesn't happen overnight, but can see the change in how child and family services sees it, how family courts see it. So those changes can happen only when people get out of their silos and begin to talk to each other at a higher level with champions that are in place.
Okay, I think we've covered all the questions. Thank you so much, Carrie and Sharon, and everybody for hanging in there with us. Zena, do you have anything for wrap up?
Yes, so this concludes our Q&A portion. As a reminder, please take a few minutes to complete the evaluation survey that is located in the chat box. Again, clicking the link will open the evaluation in your internet browser. And lastly, we would like to thank you again for your participation and hope you have a great rest of your day.